Okay, so for the last 20 minutes or so, I'm just going to give an overview of a national programme of work and also some work we've been doing locally around this, around sort of the targeting of acute kidney injury as a way to improve care and outcomes. And so the notion that sort of acute kidney injury might be seen in the system as the canary in the coal mine. So over the last 10 years in England, sort of particularly, although sort of there's work across the UK, but this is very much an NHS England programme of work, is that sort of it's emerged as a national priority. And it started with the point of a national confidential inquiry that happened in 2009. And that's led to a whole lot of policy drivers over this past 10 years. And it's still very much work in progress. But there's been a lot of work, particularly between 2014 and 17. And there's a potential opportunity, and this is a hypothesis really at the moment, opportunity to broader and tailor conversations by the acute kidney injury coming onto the agenda, sort of that you can begin to think about kidneys in the context of supporting vascular health. And you can also think about kidneys in the context of supporting better management of episodes of acute illness. And this is is there an opportunity in this happening, acute kidney injury, on coming as a new classification system to reframe and shape conversations? I'll go through detail, but acute kidney injury is common, it's harmful, it's costly, it's treatable, and it's potentially avoidable. What acute kidney injury is, it's a stress on the kidneys at a time of acute illness. And this Richard Flucker, who's the national director, would frame it. It's a clinical syndrome and refers to sudden reduction in a person's kidney function that makes maintaining fluid, electrolyte, and acid balance difficult during that episode of acute illness. It's not caused by a direct blow to the kidneys. It's not a physical blow. There's been how you detect acute kidney injury is at the moment, and it's based on routine blood tests and acute changes in someone's serum creatinine. So it's based on the sort of routine testing that's happening. It's the lab systems and algorithms detecting an acute change that might suggest someone has acute kidney injury. There are millions and millions of pounds going into the development of biomarkers to sort of detect acute kidney injury. And there's a political question, whether that's where the money should be invested, or actually are there other ways to invest the money to drive change? But that's what's happening in the scene. And there's an international classification system that I mentioned earlier that came in 2012. To reiterate, it's not another long-term condition. It's a syndrome, not a long-term condition. And it's based on this relationship. Acute kidney injury occurs in this context of episodes of acute illness, largely in people who've got multiple, the context of frailty, living with multiple long-term conditions on multiple medicines, maybe dependent on a carer from ensuring sort of fluid intake at times of acute illness. And it's in this interaction between an acute event, being exposed to something, and the underlying being susceptible to sort of having poor outcomes during that episode of acute illness. There's a colleague put this little funnel together, and it's really the context, it's the combined result of people losing fluids during acute illness, such as in flu, gastroenteritis, diarrhea and vomiting as examples, in the context of infection, sepsis, and the context of people being on medicines that normally in the stable state are there as cardiac protection, but such as antihypertensives or for treatment for heart failure. But if you're low in your blood pressure and you're low in your fluid volume and you're on these medicines, the argument is that then actually that combination reduces the perfusion to the kidneys that makes then the kidneys become under stress during that acute illness. Some cases, it's when you've got an obstruction of the urinary tract, and that might account for about 20% of cases. So there's multiple causes. And a colleague put this into animation, and that all goes into the funnel. And so it's that combined result, and that's most of what acute kidney injury is. And and they're the common drivers for people having an episode of illness complicated by AKI, as it's being termed. Intrinsic kidney disease, actually things that are happening and that a real nephrologist need to see, is a small proportion. So the point is, this is about generalist care. Acute kidney injury happens on medicine for the elderly, in the community, in an ED, post-surgical. It's not a nephrology specialty. Nephrology are leading the direction of travel with this, but it's really the potential that this is a way of improving generalist care. CKD, as mentioned, there's a whole list of people that are more susceptible to getting acute kidney injury. And that's recognizing CKD, chronic kidney disease, in the context of comorbidities. But there's evidence that people who have pre-existing reduced kidney function are also more prone to having problems with kidney function and getting acute kidney injury during their acute illness. There's a relationship between the two. And it's a marker, you can see it as a marker of illness severity. And you can see then it's sort of the argument that acute kidney injury and chronic kidney disease are maybe markers of vulnerability. Is it common? I mean, there's a range of studies, but there's evidence that it sort of it affects about 1.5% of the UK population a year, more common in the elderly. Trial-based studies, it's affecting about 6 to 8% of all hospital admissions. And it's more common in unplanned emergency admissions, maybe affecting up to 1 in 5. And largely, it's being detected at the moment, largely when people present to ED and present to hospital. But that onset is happening in the acute illness, it's happening in the community. So there's an issue about where it fits, about improving the interface of care between going into hospital. I'll come to how we can improve transitions of care for people who have then had a hospital admission complicated by AKI. Is it harmful? There's evidence it's associated with increased mortality, both in the short and long term. There's evidence that's increased risk of development of chronic kidney disease and the vascular risk that that is associated with, and the progression of chronic kidney disease. And it's also associated with high rates of rehospitalization. This is an example. This is a study that was conducted in 2 district general hospitals in Wales a few years ago. And of those 1,000 people that had an episode of illness complicated by AKI in hospital, 50% had died within 14 months. But 30 to 40% had developed or progressed their chronic kidney disease. And of the 730, so of those that died, half died in hospital, and then 733 people were discharged in this cohort. Of those, there were 492 rehospitalizations within a 6-month period. It's seen sort of that, and there's been work, and that work, say, that's conducted in Wales, has been replicated both in Scotland, and there's some big, large data set work that's happened in Canada as well. And it's seen that 90% of people who've had a hospital admission complicated with AKI are readmitted within 90 days. And the question is, what can you do about that? Is it worth focusing on? And particularly, it's people who've maybe had heart failure and they've maybe had medicine stopped quite rightly during a hospital admission. But the question is sort of that people are going back into hospital are going back in with fluid overload. And the question is there anything, and it's a question mark and it needs more work, is there anything that can be done around medicine's management at the transition of care coming out of hospital that needs more thought? Is it harmful? And this is based on the Sawney paper. And this is just showing that it's in the context, CKD is a people who've had AKI and then sort of also have chronic kidney disease, the outcomes and readmission rates are higher. And these are the main reasons for readmission. People going back, a main reason is people going back in fluid overload. It's costly. There's work done in the NHS. Costing hospital-related AKI care is about 1% of the NHS budget. And that's largely in the context of increased lengths of stay and also associated increased critical care admissions. So a question, sort of, does AKI offer a lens to improve care and outcome for people with complex health and social needs? It's a common clinical syndrome, not a long-term condition. It's a strong prognostic marker of premature cardiovascular mortality and morbidity, and it's associated with high rates of hospitalization. It is relevant across hospital settings, and it's relevant to generalist care, and it's also relevant in the context of people with frail and people multimorbidity. So is this a lens that we should be, is this a useful lens? And that's a question mark still at the moment. If we move on to sort of how it might fit or how it links to the development of the shift away from this long-term single disease framework that we've had historically in the UK setting to development of integrated care systems. This is an exemplar to begin to get work around developing integrated care systems. It's a whole shift over the last 5 years of policy papers that focus on new models of care. We've got a new NHS long-term plan that came out in January of this year, and that focuses on integrated care systems and what that means. From July, actually this month, beginning of this month, there's a new formal contract for general practice. And this on the basis that general practice has been in a trough. There's workload has gone to saturation point, people are retiring early, people aren't necessarily coming into general practice. It's become unattractive, although that might be changing again and things go in cycles. There's a new contract that's about a 5-year block of funding to look at creating stability and increased capacity in general practice, and see that general practice is integral and actually can be a responsible part of driving systems of care. So the establishment, away from sort of practices working in isolation, there's a shift of funding the development of primary care networks. And what we mean by those, it's local practices working in a geographical area. So you're looking at about 5, 6, 8 practices working together to serve a population of 30 to 50,000 people. And within that, practices are now funded to sort of do quality improvement, both in the practice, but learn to do it together. And that's a shift. The quality outcomes framework that I mentioned earlier still exists, but it's been downplayed a little bit. And practice is now incentivized to do quality improvement activity across these primary care networks. There's funding for practice pharmacists, not only for practice pharmacists to sort of be in the area, but to be the funding for them to be embedded in the practice, to be part of the team. That's already happening, but it's a formalization of that. And the other thing is happening is the formalization and funding for social prescribing link workers. The terminology of this workforce, I think, is open to changing, but that's sort of becoming part of everyday work. We've had, in our practice, I've got some colleague, Sean, his title is patient ambassador, but a lot of work about signposting people, helping look at social needs, welfare rights, addressing and reducing some of the stuckness that can happen for people and in the system as well. So that there's a formalization. This is what's happening in the funding. And I guess sort of linking to sort of this in context of people multimorbidity, which has come on the scene over the last 10 years. At the moment, there's a limited evidence base how you address sort of interventions to improve people living multimorbidity. There's a 3D study that was done in the UK, and that showed improved patient-centeredness of care, but no improvements in quality of life, no change in admissions. But that opens up conversations how to do things. Bruce Guthrie, I mentioned earlier, he had an analysis piece in the BMJ a few years ago now, but he talks about sort of really how do you adapt systems and support people living with multimorbidity. And one of his arguments is that you need to look towards syndrome-focused guidance or tools. And the question, does AKI, is that a way to, as an example of that? So it's emerged as a national priority. There's a national confidential inquiry that 10 years ago, and that really looked at people who died in hospital, had hospital admission complicated by AKI. And that showed episodes of significant, it showed people not getting good care, basic care, and that assessment of acute illness was missing. And Donal O'Donoghue, was the national clinical director at that time, said, if we can get it right for AKI, we can get basic care and generalist care right across the NHS. This isn't new. I mean, this goes back to the Korean War, and I don't know if people used to watch MASH in the past, but that was based on sort of the renal insufficiency. They looked at better systems of care, and they recognized that people who were developing AKI, they didn't call it that then, their survival was poor. And they said it was about rapid response. And the argument is if you can learn from that, you can have you get better systems of care going. The classification system came in 2012. That led, and the confidential inquiry, the classification system, NICE guidelines led to the establishment of the Think Kidneys program. And that's been a multidisciplinary program, nephrology led, but with work recognizing that they didn't want to impose things onto practice, like maybe the experience had been with chronic kidney disease. So it's been multidisciplinary, there's been patient and public representation on it, acute physicians and nephrologists, and some GPs. Key thing that's happened is that there's a national patient safety alert that's come in. And what that has meant is it mandated all acute trusts in the country and all acute lab systems in those acute trusts have had to install this algorithm. So wherever a blood test taken, any routine kidney function test taken, it gets pushed through this algorithm. So whether it's taken for just routine diabetes management in practice, or it's an acute illness, it gets pushed through. And what that generates is an acute AKI warning stage test result. And that doesn't mean someone has AKI, but it means think about, go and look at someone, and what's the context? Is it acute kidney injury? What needs to be done? And that's happening. So whether we like it or not, that's now part of the UK, or in England anyway. And these are the lab systems of the country. They have to report data back nationally. And so it shows the implementation is happening over time. And it's in the hospitals, huge amounts of work going on in hospitals around sort of looking at sort of responding to these alerts, looking at better response, about looking at fluid management, looking at stopping medicines, but then needing to restart them. And there's been trials going on in hospitals, and they showed not necessarily any change in mortality, but they did show reduction in hospital stay. But question mark, they didn't look at rehospitalizations as part of this STEP Wedge trial through the Health Foundation. So questions are, what's the role across the interface? What can primary care do in detecting and managing AKI, improving care across the at discharge, and preventing AKI? Loads of resources have been now on the Think Kidneys resource. We're keen to put things in context. How do we maximize utility and minimize burden? How do we get an evidence base that's grounded in everyday practice? And that's been a key part of the work of Think Kidneys, building up guidance that's grounded in everyday work. We put out sort of a guidance for primary care, how to respond to a test result. What we don't want is a blood test that's taken routinely at 12 o'clock on a Friday morning, gets sent by the lab man, and it gets then tested at 8 o'clock on a Friday night, and then you get a test result going to the out of hours doctor that then leads to a hospital admission at 2 in the morning because people didn't put that test result in context. We're trying to reduce that level of burden around that. We've done some papers on it about how you think about medicines, think about fluids, think about your reviewing. Post-discharge care, there's a whole sort of national guidance about practices now having to develop registers. How you improve conversation with patients is incentivized. How you make sure coding's happening, thinking about medicines management post-discharge, and the monitoring for kidney recovery. But this in the context of actually how you think about it, not just about the kidney, but the cases that you see, it's actually this AKI just been a marker of vulnerability. It might be that actually, someone is, chatting to Ben actually on Friday around someone that's maybe has type 1 diabetes, they have a enduring mental health issue, they're socially isolated, they run out of money, they run out of food, they present to hospital in diabetes crisis, and in that they get an AKI. And the AKI is just a marker of that vulnerability, and the planning post-discharge needs to be more than just sort of thinking about kidney monitoring. It's about getting a social package of care in, but AKI being a marker of that vulnerability. Put it in the context of heart failure, put it in the context of people who have diabetes, and making sure people get back on medicines. And that's work that we're looking to do over time, sort of look at understanding that medicines management gap that might be happening, particularly in the context of people with heart failure. And there have been incentives, I won't go into detail, that hospitals been incentivized to put AKI on a discharge summary as though it'll improve knowledge and improve readmissions. But what you find is that, so we did some case note reviews, and what you find is that sort of it could potentially is becoming a tariff-based discharge. Hospitals then get funded for doing this, AKI is on the discharge summary, and we, as GPs, we get this note, repeat bloods in 1 to 2 weeks, but there's no real evidence of repeating bloods in 1 to 2 weeks, but we start doing that, but that creates workload, and there's a, you know, so we need a stronger evidence base around it, and there's sort of, you know, and that creates workload for patients as well, but that's what we see, and it's sort of, there's a lack, you know, there needs to be potentially greater coordination across the interface around this. We've created some guidelines that's draft at the moment that tries to ensure there's more tailored and timely care. In the top red, it's saying maybe someone's had AKI, severe AKI, and they've got heart failure. Actually, as a system of care, we maybe want to, and the evidence based around heart failure, maybe we want to see that, coordinate a review within 3 days post-discharge. But someone who's had a milder acute kidney injury, and they've got no other medical history, and the kidneys are recovered at discharge, maybe it can wait until sort of 1 month, 3 months down the line. Things don't have, we can tailor it rather than we just get this blanket, repeat bloods in 1 to 2 weeks and shift that workload out of the hospitals, job done. There needs to be some way of coordinating the care a little bit better. Shows at the moment there's a gap. Not many people, it's not being coded in general practice. So if it is important, it's not necessarily being captured in general practice. We've done some work in the local area of Greater Manchester, building on the evidence of audit feedback, education, and developing practice level action plans. And there's a literature around audit and feedback, and there's a trial based around this combination to improve prescribing behaviors. So we just had a look at code, you know, how things, can you do anything to improve care post-discharge? And what we found is that sort of coding increased, and if you did code, it was associated with improvement in care processes, people having a medication review, people having been given written information, people having had kidney function checked. But in our qualitative work, there was a silence on how that was discussed. So it may be important, but it's insufficient, you know, insufficient. It's a starting point for conversation. I'll just, if I've got time, just the last thing on sort of preventing AKI, lots of Think Kidneys resources about how to discuss kidney health. Think Kidneys have put out resource about sort of if you're feeling unwell and you're you know, diarrhea and vomiting and things, and you're at risk of AKI, it might be best to sort of early contact and planning of care with healthcare providers at this point. But in Scotland, there's a rollout of sick day guidance, and I don't know if anyone's come across that in Australia yet, about this concept of temporary cessation of medicine. So the notion that if you're feeling unwell, you've got temperature, diarrhea and vomiting, and you're on an ACE inhibitor, that's important in the context of heart failure, or you're on a diuretic, the notion that you should stop that temporarily, and then when you're feeling better, you start it again. We've done some work around it, and we're very cautious. So Scotland had rolled that out, and it's recommended at the patient safety program. In England, we're very cautious about it because there isn't any real trial-based evidence around that at the moment. So it might be useful on an individual assessment, but systematic rollout of sick day cards on community pharmacists' tops might just create more confusion when people actually still struggle to know about kidney health in the first place. So the systematic review shows a lack of evidence. We did some qualitative work that shows that it's really sort of the misunderstandings, there's communication issues. It's not a straightforward concept to talk about this stopping this medicine and then restarting it, and it needs a little bit more work. We've linked to some work in the US around this as well. So this is, we've got a Think Kidneys position statement, and particularly don't use the word nephrotoxic has been a mantra that's come out through England, because ACE inhibitors and cardiac medicines aren't nephrotoxic, and they, you know, you need to sort of not create more confusion. So just returning, sort of classification systems can structure and constrain care, and they can provide a lens to sort of support care. And AKI has come into the UK system. It's here now, it's mandated. And the question is how we make the most of it. How do we maximize utility, but minimize burden? And I'd sort of say that sort of primary care has a really important role, and primary care's important research has a really important role in driving this to make it more meaningful. And maybe the primary care networks and quality improvement in the new contract is a way of operationalizing that and building an evidence base. So it's a lens, is it a lens to ensure safer transitions of care? So I'll end on sort of, you know, from, you know, positive, hopefully it's some positive, the Think Kidneys trying to reframe things in a positive way. And Donald O'Donnell say, if you can get it right for AKI, you can get basic rights and you can get generalist care better across the NHS. So thank you. Thanks for your time.